the Trojan horses issue is that whenever you have proposals, bills that include accommodations to Kaiser-like entities like HMOs and accountable care organizations and integrated delivery systems, you run the risk of turning a single payer system into a multi-payer system, and that brings high administrative costs and incentives to cherry pick and lemon drop and skimp on care and game documentation and cheat and things like that, which are happening rampantly all over the place in our current competitive system. So it's very important for single payer proposals and bills not to have HMO and ACO loopholes. There is a way to accommodate Kaiser, the positive aspects of Kaiser by allowing a medical group, multi-specialty medical group like Kaiser Permanente Medical Group, affiliated with a single hospital, to be paid through that hospital's global operating budget with physicians paid with salaries, which would preserve the care delivery functions of Kaiser, but strip it of its insurance function so that it would be paid, the budget would be paid by the single payer and not from subscriber premiums. So therefore it become an open system that anyone could go to for care and they wouldn't be locked into it. But you would be able to have the doctors and hospitals working closely together to integrate care as Kaiser does, but it'd be each individual hospital. It would eliminate the chain functions of Kaiser. It would eliminate the corporate offices, and each hospital would get their own budget. And that would work very nicely to preserve the positive aspects of Kaiser without the negative aspects.
And Kaiser's on board with that?
No. My son-in-law, Phil Verhoff, who's also on the board of PNHP, is a Kaiser doc here in Hawaii. And as far as we've been able to determine, the doctors would have no problem with this because the only people that would be kicked out would be the corporate people and those managing the insurance functions, the underwriters and all that kind of stuff. But the doctors would be fine with doing it that way. But if you ask Kaiser as a corporation, I'm sure they would not be fine.
It's only, and if I can add, it's only part of the corporate structure. So it's the part of the corporate structure, as Steve says, it's the insurance part of the corporate structure, because the billing part of the corporate structure, they bill the government all the time, you know, especially for, you know, for their Medicare and Medicaid patients. They're very used to billing the government. You know, Kaiser takes, you know, government sponsored plans too. So they're very used to that. And so the billing department doesn't care. You know, even capital, you know, the side that that determines capital expenditures, they also understand, you know, global budget. In fact, HMOs are very good at, you know, global budgeting. I mean, that's how they operate, right? So they look at a whole global budget as opposed to strictly fee for service kind of in terms of operations. So they're very good at that. It's just the insurance side of corporate that has a problem.
Well, billing and collections, they would no longer be collecting premiums from individual subscribers. So their billing department would shrink, but they would then be just billing the government, the single payer, and negotiating their global budget. That's all they would need to do. So it would be a smaller billing department, but they would still have that function.
So I was also wondering, Steve, one of the things that came up when I was working with KIP earlier this year, one of the problems that and you may have said it and I didn't hear it, was that when you do have these big risk-bearing HMOs and so forth, that they also, they want to make the rules.
Yes.
And so you don't have democratic oversight over the allocation of resources and stuff like that. And so is that just the insurance plan, or is that seems to me like that's also another piece of the corporate?
Well, the difference is if you're paying the corporation a global budget, and then they would decide where resources would get allocated. And they would also want to make sure there was a funding stream for their corporate office. if a single payer pays each hospital or doctor hospital, group as a group, a separate budget and negotiates the budget with each hospital, then there is no corporate function. And the single payer gets to decide which hospital needs more funding and which hospital is duplicating the services of one next door and needs to be cut back and things like that. Whereas if you pay a chain a budget, the chain would make those decisions and they would do it in their own self-interest and not in the community's interest.
Right, exactly. And that's where we go.
Yeah.
Anyway, I just wanted to make sure that I had understood that as
Yes.
part of the smorgasbord you were giving us.
That's correct. In my own thinking, I think the fundamental problem is we have to get rid of the competitive insurance business model, which says we want to take on risk, and if we take on risk, then we get the money, and we have to deal with paying for care. And when an entity is risk bearing, they then have an incentive to skimp on care and to cheat and do all the things that corporations and healthcare do. So if you get rid of the competitive insurance risk model and you pay, the single payer pays providers of care directly to deliver care without assuming insurance risk, that means the single payer handles the ups and downs of, some years have a pandemic and some years don't, and the costs vary somewhat year to year, but you end up paying the average actual cost of care. Whereas if you do contracting with risk-bearing entities, then you've got to pay them enough so that they are assured of not actually losing money, which means you're paying the top of the ups and downs all the time. And there's a large amount of money wasted on that. It's better to have the risk borne by the largest entity possible, which would be the single payer. And the bigger the pool, the risk pool, the easier it is to manage risk. And the smaller and the more fragmented it is, the more administrative complexity gets introduced in order to manage that risk. And all of it costs money. So you want to get rid of any risk-bearing entities and only have the single payer assume insurance risk.
Don't you love to listen to Steve?
What?
I would say, I just love to listen to you. You're great. You make it all so clear.
Yeah.